Hello everyone, this is Dr. Humanist again. Let us now discuss about Wilson's disease. Okay, it is disorder of copper metabolism which will lead to abnormal deposition of copper in tissues like liver, brain, kidneys, and cornea, which will lead to organ dysfunction. Okay, so it is because of the mutation in the ATP7B gene, which is located on chromosome number 13. Okay, and it follows autosomal recessive inheritance. That means what? Both the parents must be carriers of the mutated gene. Now coming to the pathophysiology, normally what happens is the dietary copper is absorbed from the small intestines, right? And then it is transported to the liver and incorporated into the ceruloplasmin. This is what normally happens. But because of the mutation of ATP7B gene, there is a failure of incorporating the copper into the ceruloplasmin and exporting copper into the bile. Okay, that's why this free copper now gets deposited in the liver, and eventually it will spill out in the blood and then deposit into the other organs like brain, kidneys, and cornea. Okay, now coming to the clinical features, mainly hepatic, neurological, psychiatrical symptoms we'll see. Hepatic manifestations around 10 to 30 years of age it will come. Okay, patient will present with either hepatitis, which will mimic like acute viral hepatitis. Okay, patient will be complaining of jaundice, abdominal pain, and hepatomegaly. Okay, next is CLD. Patients, if the Wilson's disease is untreated, might land up into chronic liver disease or even decompensated chronic liver disease. Next is fulminant hepatic failure. It is sudden onset liver failure with high mortality. Okay, and it is often associated with Coombs negative hemolytic anemia. Other than that, the complications of this liver failure can be the like portal hypertension symptoms or hepatic encephalopathy will be there. Lab findings we'll see in the next in the diagnostic section. And neurological manifestations. So age of onset is after once the liver disease has appeared, then the usually neurological manifestations will come in adolescents and to the adults. Okay, what are the clinical features? Movement disorders like tremors, dystonia, chorea, bradykinesia, dysarthria, Parkinsonism, that is the triad rigidity, bradykinesia, and the gait disturbances. Then dysphagia, dysarthria, and ataxia. Psychiatrical symptoms can also be there, like personality changes will be there, cognitive decline, psychosis, and mood disorders. Okay, ophthalmic manifestations, Kaiser Fisher rings. Okay, that is main thing. So what are those? They are brownish green ring around the cornea because of the copper deposition in Descemet's membrane of the cornea. Okay, which is visible in slit lamp examination. These cave rings are present in more than 90% cases with neurological manifestations and 50 to 60% cases with liver disease. Okay. Now, other than that, sunflower cataract also can be there because of the copper is depositing in the lens as well. Okay, but sunflower cataract is less common than the cave rings. Okay, other systems also can be involved. As I said, like renal, it will lead to RTA proximal type. Okay, RTA type 2, aminoaciduria, nephrolithiasis, cardiovascular symptoms will be there: cardiomyopathy, arrhythmia, skeletal, osteoporosis, arthritis, chondrocalcinosis. Hematological, as I said, Coombs negative hemolytic anemia will be there. Endocrine hypoparathyroidism and infertility in the woman. Now coming to the diagnosis, okay, low ceruloplasmin, typically less than 20 milligram per deciliter, but this is not specific, as serum ceruloplasmin can be low in other disorders also, like nephrotic syndrome or malnutrition. It will be low because so it's not specific. Even 10 to 20% of the Wilson's disease only the ceruloplasmin will be normal. Serum copper is also not specific because it is typically low due to low ceruloplasmin, but free copper, if you see, most of the times it will be elevated. Can also be normal. Why it is normal? Because it is excreted from the urine, right? Excessive copper is excreted from the urine and it is getting deposited into the organs and tissues. So the Wilson's disease, the main thing is the problems are because of the deposition of the copper, not because of the increased copper into the blood. Okay, next is the specific test. You can first go for 24-hour urine copper excretion, right? Elevated, which is elevated more than 100 micrograms per day. Okay, other than that, you can go for liver biopsy. Okay, that is copper deposition in the liver tissues, which will be more than 250 microgram per gram of dry weight of the liver tissue. Okay, then genetic testing to see the mutations in the ATP7B gene. Okay, these three tests are specific. These values you have to remember: urine copper more than 100 microgram, and liver biopsy more than 250 microgram per gram of liver tissue. Okay. Other than that, you can go for imaging testing like slit lamp examination for cave rings, MRI brain to see that will show changes in the basal ganglia, and face of giant panda sign will be there because of the atrophy in the midbrain. Right. Now coming to the treatment. So main treatment is, first line is copper chelators. Okay. What are those copper chelators? Mainly two: D-penicillamine and triantine. D-penicillamine, what it does is it enhances the urine excretion of the copper. Right. Now the dose is 250 to 500 milligram per day initially, but you can raise up to 1 to 2 gram per day. Okay, side effects of D-penicillamine is proteinuria, nephrotic syndrome, bone marrow suppression, and lupus-like syndrome. Okay. Triantine, on the other hand, it can be used as an alternative to penicillamine in cases of either intolerance or side effects. Okay. The dosage is 750 milligram or 1.2 gram per day, which is divided into 2 to 3 doses. Side effects of triantine: iron deficiency, anemia, and gastritis. Zinc, on the other hand, so what zinc does is it will block the intestinal absorption by it induces metallothionein. Okay, what this metallothionein will do is it will bind to the copper, that is dietary copper, and it prevents its absorption into the blood, right? And the dose is 50 milligram of elemental zinc 2 to 3 times per day. It is well tolerated and it is used as a maintenance therapy, okay, or in the combination with the other chelators like D-penicillamine. Okay, and dietary copper restriction has to be done. Okay, we have to avoid foods with high copper like shellfish, liver, mushrooms, nuts, chocolates, and legumes. And you have to test the drinking water; it should be low in copper content, right? And you have to avoid the copper cookware. Okay, liver transplantation has to be considered in the patients with fulminant liver failure or end-stage cirrhosis that does not respond to the medical therapy. Okay, and it's seen that liver transplantation corrects the metabolic defect and is curative also. Okay, symptomatic management, like for spasticity you can use baclofen, for Parkinson's you can use levodopa, and for tremors clonazepam or propranolol can be used. So prognosis, obviously untreated Wilson's disease can be fatal, mainly because of the liver failure and the complications associated with that. Also, even the neurological involvement. Okay, so with appropriate lifelong treatment, patients can live normal or near normal lives. Okay, as I said, liver transplantation is curative for the patients with advanced liver disease, and neurological symptoms also with the treatment will improve over time. But some patients might have some residual deficits. Okay, follow up and monitor, it is very much necessary. Lifelong monitoring, treatment and monitoring is necessary. In follow up, what we do is we'll see the organ functions like liver function, CBC, and 24-hour urine copper excretion to see the disease activity. Okay, so dosage of zinc therapy and chelation will be adjusted based on the copper levels only. Okay, and periodically we can also do neurological evaluation and slit lamp examination, right? So this was a discussion on Wilson's disease. Do read about this. Thank you.